Hi everyone, I'm Sandeep. I'm one of the cardiology fellows here at the University of Arizona. As a part of my OA elective, I had a chance to work with Dr. Gray at Greenville, and this is one of the cases I want to share with you. So we had a 42-year-old lady who was referred to us for 2 months of right lower extremities pain and swelling with no clear diagnosis. She's a Caucasian lady, no significant risk factors for DVT or any other comorbidities. She was mildly overweight. On examination, she was hemodynamically stable. She had no signs or symptoms concerning for phlegmasia. There was pitting edema and erythrocyanosis with dilated veins. No inguinal lymphadenopathy or masses. She's already had two venous duplexes, both of which were negative for any DVTs. She had a CT of her pelvis without contrast that showed an ovarian cyst, but did not comment on anything specific. We looked at the CT scan ourselves and we saw that there was this mild uh, haziness in the right external iliac area. Her labs were fairly fine and thrombophilic workup was negative. Of note, there was no diagnosis of DVT at the time the thrombophilic workup was completed. The clinical picture was very concerning for DVT, so the primary team had already initiated rivaroxaban at the time of referral. When we saw the CAT scan and we found that things were not adding up the right way, we got a third venous duplex with a focus on the external iliac veins to see if there's anything that we can see over there. There was some abnormal flow, but again, we couldn't really clinch the diagnosis of a thrombus. Just the fact that things were not adding up well, we decided to proceed with the venogram. Right common femoral vein axis, as you can see here, and there's complete occlusion of the right external iliac vein with abundant collaterals providing the flow back. We did a pulse spray of thrombectomy, TPA, and did aspiration thrombectomy, which, as you can see here, there was recanalization of the external iliac vein and the common iliac vein. However, if you look closely, there is still some intraluminal filling defect, and there is this aneurysmal dilatation of the right external iliac vein. So if you look at the whole case together, she did have symptoms suggestive of obstruction of the veins. We did give a pulse spray of thrombectomy. Things did get better. There was recanalization of the external iliac vein. So we decided to leave the catheter there and bring her back in 12 to 24 hours to see what would change. So what did you expect to find on day 2 after 12 to 28 hours of thrombolytic therapy? Nothing different from what we left her on day 1. So as you can see, there is still this intraluminal filling defect, and which did not resolve at 12 to almost at 14 hours of thrombolytic therapy. At this point, we were concerned that this is possibly some mass, so we went on to actually put a bioptome through the sheath and get some tissue out. And what was the diagnosis? It was leiomyosarcoma. At the time of the diagnosis, there was no metastatic foci, so we did a complete CT head, chest, abdomen, pelvis. Everything was fine. She saw an oncologist, an orthopedician, ended up with disarticulation of the right hip with complete pelvic debridement. Unfortunately, 6 months later, this is what we see. She has mets everywhere, in her left thigh, liver. A quick discussion on leiomyosarcoma. It's a rare cancer. So if you look at all cancers, it's less than 1% of all cancers. Leiomyosarcoma can involve the IVC and its branches, and it's up to less than 0.5% of all the cases. It's often missed, and patients usually present with symptoms very similar to what our patient presented with. It often metastasizes early into the liver and lungs. Surgery is the cornerstone of treatment, but radiation and chemotherapy can be tried with anthracyclines and gemcitabine. If you look at the literature, there's no real classic treatment protocol because this is a fairly rare malignancy, and there's not a whole lot of literature out there. Prognosis is usually poor and patients often relapse, like in our case. When there was a relapse, our patient decided to proceed with hospice and end all the treatment strategies. Few quick take-home points. In venous cases, sometimes the diagnosis is obvious. You get a venous duplex, a CT venogram, you get the diagnosis. Sometimes it's not so simple and straightforward, and in those cases, don't hesitate to proceed with the venogram to actually get the diagnosis. You need a multimodality approach in these complex cases, zebras as we would call it. Malignancies are rare, and uh, if things don't add up, just keep it in one of your differentials. A word of caution on shotgun approach in thrombophilia testing, partly because if this patient had factor V Leiden mutation, everyone would have resigned this as a thrombus and she would have been on rivaroxaban only till we actually diagnose the mets and everything. In fact, factor V Leiden mutation can be present in up to 5% of the population, and not everyone actually goes on to develop a venous thrombosis. So just be careful before you just do a shotgun thrombophilia testing, especially when you don't have a clear diagnosis. And a special thanks to Dr. Gray for letting me participate in this case.